Where we have gaps in rural community, we want to make sure that services can be available, particularly on a crisis basis, that people can get services quickly within the areas that they're living in. So those are some of the examples. We'll be expanding on certified community behavioral health centers in our rural areas as well.
Representative Campbell. Did you have a follow-up? I'll come back to you. I like your idea. I'm trying to follow your lead. Okay.
Thank you, Mr. Chair. I'm going to refer to slide 6 here for a moment. And are you, like, for what we're designating program dollars, is that falling under the umbrella of administrative costs?
Deputy Secretary, go ahead.
No, programmatic dollars are those activities that are a part, some of the things that I just described for Senator Adcock, programmatic activities, so the actual services or initiatives that we will be implementing as a part of the application.
Did you want to have a clarifying instead of a second question? Do you want to just have a clarifying?
Just the concern when, like on slide 6, just kind of the descriptions are quite vague and sound more administrative-ish than actual delivery and execution. It's easy to hit a cap of administrative costs when we take a lot of administrative costs and call them something else. I look forward to further clarification of actual delivery of health care to rural North Carolinians. Thank you.
Thank you. Representative Reeder.
Thank you. One comment and a question. On 15, when we talk about first episode of psychosis and mobile opioid treatment, it's remarkable that we're going to put money into psychosis treatment and opioid treatment. At the same time, we have a report out that is trying to legalize marijuana when we know that there's a 4-time higher likelihood of psychosis when young adults use marijuana. So we're funding money for a program that we're getting ready to exacerbate. So that's my editorial comment. If my question, when we get back into the KPIs, do we have our performance on some of these KPIs right now? And are these KPIs going to be specific to the rural areas that we designate? So we could say, that the number of patients transferred or prenatal care, but are these KPIs specific to rural areas? And then how are we going to define those rural areas to make sure that our KPIs match up to that? Thank you.
Deputy Secretary, go ahead.
Yes, thank you for that question. So the KPIs will be specific to the rural areas. Each of the Roots hubs will need to report to us, and we'll define the reporting parameters, but they'll need to define sort of how the numbers on how many patients, as the example that you use, are being transported. So they have to provide at the individual level, and in some cases we're also tracking activity level metrics as well, but these will track individuals and activities within those rural communities. And then your second question, just to clarify.
Well, the question would be, on these outcomes, do we know what the existing performance is? Because we could say we want a 15% reduction, but if we're already at a very high or very low, that's really a percent reduction may be meaningless when we talk about the actual counts. And so if in subsequent we could get what our performance is, if we know.
Good.
Yes, sir, absolutely. We need to establish, in some cases, baselines are already established, and then we have to sort of determine the starting point. But yes, some exist, and where they don't exist, we will identify the baseline so that we can measure the percent of progress. So that will be a part of our considerations as we gather and report data.
Thank you. Representative White.
Thank you, Mr. Chair. On page 13, which is not numbered, but it's between 12 and 14, so I'm assuming y'all mean it was 13. The third item, Roots-led regional nutrition access, the chairs took the HOP program out of the budget that we don't have yet, but it still was taken out. And so is this replacing the HOP program? Is this going to be the HOP program?
Go ahead, Deputy
Sir.
Secretary.
This does not replace the HOPS program. The Rural Health Transformation Program allows us to pay for not purchase food, but pay for sort of infrastructure to support access to food. As an example, we could partner with farmers who either want to make their foods available to hospitals. We can pay for sort of making some of those supports possible, but the CMS regulations have some specific prohibitions against purchasing food. So it does not replace HOPS, but it helps us look at how can we help people access food, because access to healthy food is such an important part of improved health. We're looking at what are ways that we can support better nutrition and better nutrition access for people in rural communities without actually paying for food.
Follow up.
We're going to come back around, because I started that with Senator Adcock, and she's on the list. You're back right on the list, so I'll get back to you.
I may forget what she just said if you don't let me go now.
All right, for you, I'm going to make an exception. Go right ahead.
This sounds like HOP. So
HOP
I
Light.
really need you to go back and look at it very closely and make sure that it is not HOP, because it was duly by both chambers voted out, and we need to make sure that we know what's going back in.
Representative Liu.
Could you tell us more about the workforce initiative? Just give us a breakdown exactly these dollars and how many doctors we will be able to help, or how many nurses, or what type of clinicians we would be able to help with the dollars we provide here.
Deputy Secretary, go ahead.
Thank you for that question. So our workforce initiatives include a variety of things. It includes being able to help attract providers into the community. Part of that is focused on bringing different types of providers, making sure providers can operate to the full extent of their licenses. How can we use pharmacists as an example to deliver care when appropriate and within the scope of their license? How can we expand on emergency medical technicians? How do we focus on rural residency training programs? I think we're going to hear some more about that today. So it's a variety of initiatives focused on identifying where we have gaps in our workforce and what can we do to fill those gaps. And we will have some measures, I think, in our application that looks at the number of additional providers in our rural communities. That will be one of the ways that we track our success. But this is focused on what are the things necessary to be able to keep those providers working in those communities. And that's training, consultation, other things like that.
Thank you. Representative Cunningham. Co-Chair Cunningham.
Thank you, Mr. Chair. Secretary Farrington, on page 8, you got 27 full-time. Page 9, you got 61. That'll make a total of 88 onboarding the staff that you would have to find.
Deputy Secretary, that's a question.
Thank you, sir. Yes, ma'am. These are numbers that we planned up to. So we have only currently, happy to report, we've hired one person. We wanted to plan for the maximum number of staff we thought we would need. 27 is the up to number that would exist in the office, and then we could have the remaining up to 60 people working specifically on the programs. But we don't believe that we're going to hire that many people, but we needed to plan for it, and CMS approved that to give us the best possibility to have the right number of staff to deliver on the program. We really want to be successful with this program, and if we are successful in year 1, we'll get additional dollars in year 2.
Do I have a follow-up?
Since I'll let Representative Watt do it, then I'm coming, you're next.
So one follow-up, Secretary Farrington. I noticed on page 15, I didn't see the number about the mobile opioid treatment units. And one of the things, when I attended the Opioid Fellows Program in Colorado, is they said the mobile units are very expensive to do the upkeep, and they really weren't built to go up into the mountains. So what are our options when we're looking at long-term and sustainability, because the maintenance is so significantly high to maintain the mobile unit?
Deputy Secretary.
Thank you, Representative Cunningham. That's something that I'd like to get back with you on as I get information from our folks in DMH who's working specifically on this.
Thank you.
And I
Senator Adcock.
appreciate you raising the concern.
Thank you. Senator Adcock.
Thank you, Mr. Chair. So it occurs to me that of these 6 categories, they're not going to be happening sequentially. A lot of these things are going to be happening at the same time, right? And so as I think about the technical assistance piece, going back to slide 15 and the first psychosis episode, it's really going to be critical to get these rural providers, whoever they are, connected to the HIE, because how else are you going to know it's a first episode? Because they may be alone, you don't know. They may have family with them. They don't know what that first diagnosis was. So that's my first thought. And then the second is I really appreciate what you said about trying to avoid redundancy and duplication. So as you look at slide 11 and you look at the identifying each region's health gaps, what we know is that every county does a needs assessment of their own. I think it's every 2 years. I participated in one for Wake County. Will that information be used kind of as the baseline and the floor to then look at the region as a whole, or will they start from scratch to look at the gaps in care in the region? Can you answer that? Thanks.
Thank you for that question, Senator Adcock. Excellent question. We wrote the application that the Roots Hub could use existing needs assessments. Now, they may need to add to that, right, if there's been some additional information that's been gathered since the needs assessment was completed. We want it to be timely. We want it to be accurate and reflect the current needs, but they absolutely can use existing information. And I think given the pace at which we need to move, I can't imagine that they won't have to pull on some of those existing.
Representative Reeder.
Thanks very much. A lot of questions today about the administrative costs and appropriate, so and appreciate you and the department and the secretary working to minimize that. And I guess I'm a little perplexed because when I would start a project, I would say, this is the work that needs to be done. And I would say, what is it going to take? How many people to do that? It seems to me that what you've come to is to say, here's the budget and how many people can we fill this? And so I'd be very interested to know what work these people are going to be doing in the administrative realm. If you have the detail to say, we know that this person is going to do X, Y, or Z, as opposed to coming at it and saying, here's our total budget, we're going to hire a bunch of people, and if we don't need that many. So I'm just wondering, have you gone through that exercise to say, here's the work product that we need, and this is what it's going to take to do it? And if you have, that would be very helpful to me, and I think many of the members of the committee, because right now, I don't think many of us have a good sense of what work is going to be done.
Go ahead, Deputy Secretary.
Thank you for that. I appreciate that question. Our process for developing this budget, and I do want to highlight, not as an excuse, but just as an explanation, that we developed this application in a very accelerated time period. But our process, we identified leads for each of these initiatives. And we helped to, based on the feedback we got from the community, we designed the initiative and the 6 initiatives interconnected to make our whole program. We asked those initiative leads, what are the staff you need to deliver on this body of work? And each of the initiative leads, and I'm trying to speak in the mic, but acknowledging your question, each of those initiative leads identified a number of FTEs that would be focused specifically on that work. For us, that's why we think we got to a larger number, because we did allow the initiative leads to provide that input. And what we're doing now to validate that is we've asked them to give us some specific information. Was the original number you proposed? How did you validate that? Can you reduce that number? And we have job descriptions that will be required for each of the positions that we land on. So there's first process, got an input from the initiative lead. The second process that we're using at the agency level is to validate those numbers, and then we'll have job descriptions that are built and reviewed by our HR department to specify the duties and to make sure that they are aligned with what we can afford.
Thank you. I'm going to try to keep us on time. If anyone has any follow-up questions, if you'll send them to us, Christy will send them to the department, get the answers, and then just send them out to everybody on the committee. I do want to make a couple of statements. So one is, I hope there is going to be some kind of dashboard. I would like to be able, and I think all of us would be able to track how we're spending the money. I mean, I want to see how we're actually spending the dollars. who they're going to, what they're being used for. I almost want to see a checkbook register where we can see how all the money's being spent. And also, we need to have really tight, quick evaluations of services. So, and I've mentioned it to both of you this morning, we need to learn to fail fast. We need to, if someone's not doing the work, we need to get them out of the system and not be spending money that's not going to be doing a return. And then lastly, Mr. Secretary, I am very concerned, like Dr. Reeder, about this commission on marijuana. Rural North Carolina, and I'll use Harnett County as an area, we fight it all the time. We have people involuntary committed that are dealing with it. I'm not going to put you on the record on your opinion on it, but here we are talking about spending money in rural health care and trying to make people healthier, and at the same time, we have a commission that's recommending legalization of marijuana, which, and Dr. Reeder, I liked what you said, and I agree with you about the psychosis, especially in young people. So I hope you'll think about that. And anyway, that's my conversation about that subject. All right. We will move on. And I said, if anybody thank you both for being here. And you have got a big subject to tackle, and we appreciate you working on it. It is a real delight for me to have, and us to have, Catherine Restrepo Martin. And I had to put that middle name in there because that's how I first met you. And I had the great honor of working with her right out of the bat when I got here. She was advisor to all of us healthcare folks in the Senate, did a fantastic job. And this is the first time you've been on that seat, right? You need to make a picture. So make a picture so that we've got this memorialized of her presenting. And it's a delight to have you here and talking about UNC health system. So turn it over to you.
Thank you, Chairman Bergen. Members of the committee, it's a pleasure to be here this morning. My name is Catherine Restrepo Martin. I'm the Vice President of Health Affairs at the UNC System Office. And today I'll be providing you two updates, one on our nursing program expansion initiative, and the other update I'll be providing a brief overview of our Rural Residency Training Fund that received significant legislative appropriations in the 2023 state budget for both of these initiatives. 3 years ago, the legislature asked, what would it take for nursing programs to expand degrees by 50%? This is largely in response to the nursing workforce shortage. And I'm pleased to report today that collectively across all 12 of our nursing programs, 12 of our 16 public universities offer nursing programs. We are on a trajectory to expand nursing degrees by 60% within a 5-year period. So this is just a quick landscape map of where our 12 of our 16 public universities are that offer nursing degrees. As far west as Western Carolina, all the way to the east at ECU. ECU is the largest school of nursing in our UNC system. And that 60% nursing degree increase translates to about 700 degrees. It's actually 707, but for a benchmark number, we'll go 700 at this point. And then if you look at projected in-state retention. This is based off of SHEPS data. You're very familiar with the SHEPS NurseCast model that was released a couple of years ago that looks like in-state retention based on community colleges, UNC system, nursing programs as far as their graduate diffusion tool that looks at where are nurses practicing and what type of healthcare setting 2 years after licensure. So our projected in-state retention, we're looking at average across our universities at the 77% when we look at that data. And again, this decision, this big initiative was largely based on the SHEPS data that was released back in 2021. It's projected of 12,500 RN shortage. There's different variables, different scenarios that you can toggle around with on their website that looks at, worst case scenarios of up to 18,600 shortage of nurses. This is more of a baseline scenario. And so this is what our expansion initiatives are based off of. And this was made possible with a large infusion of state dollars. This is the fund source comes from the ARPA Temporary Savings Fund, which is really a state savings from the federal temporary enhanced federal match rate because the state expanded Medicaid back in 2023 state budget. And so this $40 million, 29 million of this 40 million was allocated through a competitive RFP process to all 12 of our nursing programs. I would also like to mention, the UNC system recognizes, we're a leader, we are a key producer of nurses. And we also recognize that there is a whole host of other healthcare professional shortages. We recognize that. We know there's maldistribution issues for physicians, for behavioral health, but we wanted to go all in on nursing with this flexible, snappy, if you will, because the nursing shortage is really the most severe. It is among the most severe when it comes to various health professions and the landscape. So I just wanted to point out that this budget snappy specifically mentioned that the UNC system had the flexibility to expand healthcare-related degree programs. It didn't specifically mention nursing, but again, using data-driven decision-making, that's why we decided to go with nursing. I'd also like to note, going back to this slide again, is that these funds are incredibly flexible because they also do not revert. And I just wanted to mention that this has been really great to work with all the nursing schools who have been able to thoughtfully implement and map out multi-year responsible expansion plans. Some schools are able to expand their doubling enrollment within a 2-year period. Others, it may take up to 4 years. And because this is one-time funding, we're adamant that these funds have to be self-sustaining, so the programs and the universities are taking it upon themselves in the event that they have to hire more faculty to expand their programs, that this is a self-sustaining, it will be self-sustaining. The universities will sustain these positions combined with tuition receipts coming in due to expansion. And while there is a shortage of nursing, there is not a shortage of the student demand. It is a highly competitive field. Members of this committee are nurses themselves and know that. Look at ECU, it looks at a cohort of 250 per cohort when you look at incoming juniors and seniors for class sizes, and 1 in 3 or 1 in 4 qualified applicants are turned away simply because of capacity issues. And there is a perception out there that because there's a nursing shortage, we need to recruit and pull people in who want to be, to incentivize them, want them to go into the nursing profession, but that's really quite the opposite. There's just so much demand versus the available capacity to take on these students. And so this is why this appropriation has helped so much on the expansion efforts and just securing the needed infrastructure to make this happen in a self-sustaining way. So again, what does it take to increase? I mentioned about faculty. As a clinician, you make more than, typically you earn more income than being a faculty member at a public university, so that is one of the key barriers to expansion. You also need simulation lab space and equipment. The Board of Nursing authorizes nursing schools to have their students complete 50% of their required clinical training hours in a simulation lab environment. This is also a key to expansion. Many schools have renovated old classrooms, old computer labs to pull in more mannequins, bed spaces for their students to get more simulation repetitions and to build competence when it comes to patient care. And then there's clinical training sites. There's preceptor shortages. It's a competitive race out there with all these various health professionals and the required training programs clinical training hours to graduate on time. And so again, this is another barrier to expansion as far as just finding more clinical placements to place their students. And then mentors. And when I mean mentors, I mean preceptors. I think a great example of what some schools are using is that A&T, specifically A&T University, is using their nursing grant award funds to they've provided scholarships for their first DNP cohort to serve as preceptors for their pre-licensure pipeline students. So I just feel like the timing of launching the inaugural DNP cohort while also improving their pre-licensure pathway and improving graduation rates on time has been a really innovative component of their proposal. And then obviously there's student supports for pre-nursing and nursing students. Some schools, their enrollment is increasing, but their on-time graduation rates are not strong, or they fluctuate. That could be for life events, financial reasons. And so we have student supports, financial supports, scholarships, or tutors, students helping students. A big weed out class to be admitted into the nursing as your prerequisite component is chemistry, anatomy and physiology, biology. So some schools are using math majors as students for BSN students, or tutoring BSN students. So as part of this entire effort, as part of this $29 million appropriation that has gone directly out to all 12, we have contracted with the Shep Center because they've had wonderful data on the nursing workforce shortage, but just to conduct a 5-year evaluation. What is the actual impact of these grants? What does enrollment, attrition, program graduates look like across a 5-year period? They're also going to be following these cohorts into the workforce to look at the retention component as well, which kind of follows along the heels of their graduate diffusion tool that they created as well. And use of simulation lab space by course is something else that they're going to be tracking. We're in year 2 of our 5-year evaluation at this point right now, and we'll be issuing a survey out to all the deans and department chairs who have been such tremendous partners in this entire effort. They've been wonderful to work with and just so committed to producing excellent quality nurses on a statewide basis to improve the workforce. And we'll be asking them more detailed questions, even more detailed beyond what the Board of Nursing requires, just to get an ultimate sense of what is the actual impact of ROI of these grant dollars. So just to talk a little bit about some of the schools just picked from the west, the central part, and the eastern, semi-eastern, southeastern part of the state, can talk more about specific examples that the members may have questions about in the Q&A. But Western Carolina is a pretty straightforward proposal. They are seeking to double their pre-licensure enrollment within a 4-year period. They've also just launched a direct entry master's program with a rural generalist focus. So it's going to have more of a population health focus for their pre-licensure graduates, while also having the master's degree at the same time. UNC Greensboro, I've been incredibly impressed with their proposal and their efforts. They just got approval from the Board of Nursing for an enrollment cap increase from 330 at this point to 880. They are launching a first-year direct admit program, which will be their normal operational model starting in academic year 2027, in which students who are enrolled and in the nursing program, in their traditional nursing program, their freshman year instead of normally their junior year, which is typically how traditional BSN program works. And they start taking core nursing courses their sophomore year. So this is, I just want to credit Dean Barksdale. She has been an amazing leader in this nursing space. She's an incredibly seasoned dean, has lots of experience, and is being able to do this with hiring 7 faculty from our fund, in addition to UNC Greensboro using their own operating budget dollars to sustain this effort. Fayetteville State University just met with their new nursing leadership a couple weeks ago. Their recent department chair just retired. She was wonderful as well. Just feel like there's a lot of fresh energy in this space, and they're actually seeking a Board of Nursing increase this fall. They're currently enrolled at an all-time high in their pre-licensure pathways. Their accelerated BSN program, which is separate from the traditional program that's typically a 12 to 14 month program, has doubled in 1 year. They just launched it maybe 1 or 2 years ago. And they're projected to increase their enrollment by 71% through academic year 27-28, I believe. And so just met with them. They've asked for a reallocation proposal from their nursing grant award. And that's another thing that I want to mention, is that the system office wants these dollars to work for each school. And each school may have received funding and their grant award that ultimately they think could be better used for something else. Maybe it should be used more for student supports instead of hiring somebody else, or hiring another faculty member. And it's gone really smoothly so far. So we want to be flexible, and we have been flexible with the schools. So again, just to close, this this timeline is really how it all started. Back in 2021, when the NurseCast model was established by the Shep Center, paid for by the Board of Nursing. And in 2022, in the short session budget, the legislature asked, what would it take and what does it take to increase nursing degrees by 50%? And then followed by the key appropriation, that $40 million flexible appropriation in the 2023 state budget. And now we've contracted with the Shep Center, and we're in year 2 of our year 5 evaluation. So I'd be happy to take any questions.
Thank you so much, Ms. Martin. And Mr. Secretary, I found a place for you to put some of that rural transformation money to help out. So there she is. You all meet right after we get through and work that out. So Co-Chair Cunningham, you have the first question.
Thank you, Mr. Chair. Vice President is Catherine, right? Martin. You know, I'm a Winston-Salem State grad, and I was shocked not to see them in there. But who is the top producer of nurses in the state of North Carolina?
Which school or?
Which one, that public? Yes.
ECU.
Okay.
ECU has the largest student body of pre-licensure nursing, yes.
Okay,
We're going to
so,
allow a question and a follow-up, so I'll get back in everybody's good grace.
Thank you.
Follow-up.
so the second question I was going to ask you is in reference to your advanced educators. What the focus has been on that, because that seemed to have been the issue of being able to take on the additional students.
Vice President Martin.
Advanced, do you mind elaborating on that a little bit more?
If you don't have the nurses that are already trained to train the trainers, you know, the educators that are in the classroom that are already professors, that was the issue of getting enough to stay. A lot of them were retiring or they were aging out.
Yes, thank you for the question, Representative Cunningham. And to respond to that, you know, I would say that most of the faculty that the schools were awarded funds for to hire to expand their program, it has not been an issue to be able to hire them within a year or two's time since these funds were allocated. I can confidently say that. I would also say that it has been helpful, and we're appreciative of the legislature appropriating a 10 to 15% salary increase from the last 2023 state budget. We have not really done an analysis specifically on the outcomes of that, but we do feel like that has been helpful.
Thank you.
Thank you. Representative Campbell.
Thank you, Mr. Chair. Looking at the institutions here, and forgive, this is probably just my ignorance. With this degree expansion, is this all BSN?
Yes, thank you for the question, Representative Campbell. Yes,
Go ahead.
yes, our initiative has focused primarily on net increase of pre-licensure BSN graduates at the university level, yes, and to respond to the nursing workforce shortage. So we have not spent dollars for RN to BSN programs. Many of our schools offer online RN to BSN programs. It is specifically for net increase of new pre-licensure nursing graduates.
Follow-up.
Are we aware of any programs that, like, I think this is great, please don't misinterpret. I think this is great, but there are more rapid pathways to address this shortage. Are there initiatives for RN training, not necessarily BSN training, that would mirror this?
Vice President Martin.
Yes, that's a great question. I will say that I'd like to speak a little bit more about our accelerated BSN program. I think UNC Charlotte's actually really innovative in what they're doing. So most times when you go through an ABSN, an accelerated BSN program, you're required to have a bachelor's degree already, and you go back to school. It's not uncommon for, because of the slide that I just looked at with ECU's case example of, more qualified applicants and then available capacity for those students to go on. They don't get admitted to nursing. They finish out in a major in psychology, for example, and then they go back to school to get their ABSN in nursing. And so what UNC Charlotte is doing, to my knowledge at this point, they're the only school in the system that has an ABSN program, but you don't need to have a bachelor's. They're actually pulling from local community colleges for students who have an associate of arts or sciences and have already the general education requirements to then fulfill that 12 to 14 month program that they offer. And it's more competitive because it's a lower price point compared to their private private universities that offer BSNs.
Senator Adcock.
Thank you, Mr. Chair. What a rich and wonderful presentation. I say that as a proud nurse on this committee. This is a wonderful exemplar of an occupational licensing board gathering data in this General Assembly, taking it to heart, asking what would it take and then funding it and not making it revert. I mean, it just hits every note, checks every box on the best way to go. So I would add this to what Representative Campbell said about the emphasis on BSN graduates, is that you're certainly building a wonderful pipeline of bedside nurses, but you're also setting the table for those nurses then to become faculty and advanced practice providers. And we know that we cannot do this without the faculty, right? So, I mean, it's broader even than that, putting nurses by the bedside, which is great. My question is, for those in the audience who don't know, describe a little bit about what simulation really means these days, because it's not your daddy's simulation. This is not, Annie the mannequin. This is really 21st century simulation that adds such a rich experience to nursing and other kinds of education if you do that.
Yes, sure.
Thank you so much.
Yes, thank you, Senator Adcock, for the question. You're probably more equipped to answer that or explain that than I am, but I have gone out to all 12 universities that offer nursing programs. I've visited their simulation labs. They have high-fidelity simulation mannequins. Many of them purchase them for NICU baby mannequins, adult gero patients, because when students are required to get their clinical training hours in at an actual clinical partner site, whether that's a hospital, nursing home, other healthcare setting, they may not be observing certain patient scenarios at that point in time. And so simulation labs are an excellent way to boost competence and confidence for nursing students to be truly prepared in the workforce. So you have sim coordinators, you have sim personnel, you have technicians who are running the labs, putting schedules together, working with the faculty, and they create these patient scenarios where the students come in and work together, and actually works really incredible in an interprofessional setting as well.
Do you have a follow-up?
You did a great job on that, and I just wanted to add my shout out to the dean at UNCG, Deborah Barksdale. You nailed it. She's great. Thank you.
Representative Lou.
Thank you, Mr. Chair. Incredible work that's been done in the last 5 years. I'm just curious if you see a role that private institutions may play in addressing this need. I do see there's competition between our private and public institutions, or you see there are ways that they can collaborate and provide support, because there's such a huge need. And I know programs like Meredith, they would love to, get, the support.
Yeah, I think, thank you for the question. That's a great question. And I guess I would say, really, looking at our 5-year evaluation that we've contracted with the SHEPS. I mean, SHEPS represents healthcare workforce statewide. They're looking at community colleges, they're looking at privates and independents. And so I think it would be really interesting if this evaluation could extend out to the community college system, to the privates and independents as well, to look at the full landscape.
Representative Blackwell. It's good to see you, sir.
Thank you. Sorry to be late. 2 questions, if I may. If I understand correctly, all these programs you've been describing, I think you mentioned an accelerated program, but they're all basically what I would call a 4-year degree program, correct?
Yes, it is. It is the pathway to becoming a pre-licensure registered nurse.
Right.
The bachelor's level, yes, and there's different pathways to
Okay, and so here's my question on that. Given the shortage that we've got, and the urgent need that we have, what do we get for a 4-year nurse that we don't get with a 2-year nurse? Have we got things backwards if we, faced with an urgent need, pick the solution that takes the longest to provide us with the nurses we need?
Yeah,
President Martin.
Representative Blackwell, I think that's an excellent point. I would say this is a collective effort. Community colleges are another key producer of nursing in our state. And That's why we have accelerated programs. Our universities are offering shorter pathways, but still not compromising the quality of education to become a pre-licensure Bachelor's Science of Nursing. I would also say that there are studies out there that show that BSN nursing students, it puts them in more of a position for leadership positions, administrative positions in the hospital setting as well.
Senator Jarvis.
Thank you, Mr. Chair, and thank you, Catherine. Great presentation. I had to do a second take whenever I seen you there this morning. I said, whoa, you're in the wrong place. No, congratulations.
She's in the right place then.
She's in the right place. I want to sort of capitalize on Representative Blackwell talking about the community college system. You say this is a better pathway to get them into the hospitals, but the hospitals isn't necessarily where we need all the nurses. I think our community colleges are being missed by not trying to capitalize and put funding that would be a much less costly program to get the nurses we need immediately with such a shortage.
Thank you for the question, sir. Thank you for the question, Senator Jarvis. I would also say, looking at the 2023 State Budget Act, there was also significant fundings appropriated to the community colleges for high-cost workforce programs and for nursing specifically. Again, our fund source, the $40 million, comes from the same fund source of the Medicaid expansion bonus funding that was appropriated in the 2023 state budget. And in fact, I believe that the community college system received more than the UNC system.
And Catherine, would you, if you, as you were talking and you understand the process, as legislative process, if there's something we as a body needs to we need to pass, or if there's some roadblock that we're stopping some things from happening, if you'll let us know, and we'll look at legislation to try to help the process and get the folks out. But I agree with Senator Jarvis. The community colleges have a pivotal role in this, and I know they are all working to increase and I see all the folks from SHIP Center and everybody shaking their heads. Everybody's working on the same thing from different avenues, but thank you. All right, we're going to close this section. We're going to open another section with Vice President Catherine Martin to talk, and so we'll talk about rural residency.
All right, so round two. I'll be providing you another update on another key significant funding appropriation from the 2023 state budget to the UNC System office. This is the UNC System Rural Residency Medical Education and Training Fund. So I just spoke about the nursing shortage, but we're excited to talk about this fund today in partnership with Dr. Emily Hawes at the SHEP Center. She is the director of the technical assistance team for implementing rural residency training across ECU and UNC Health and other eligible entities that are part of this fund, which we'll talk about in a little bit. But the data is clear that physicians are more likely to practice in rural areas. They're 2 to 5 times more likely to practice in rural areas if they do a significant or just a little bit of portion of training in rural areas. And if we go to the next slide, today's agenda, I'll just talk about a little bit about this fund, but we want to look at the actual landscape right now. So many of you are familiar. North Carolina clearly needs more rural doctors. Many of you are familiar with this annual report produced by the SHEP Center that's submitted to the legislature every year. This is a legislatively mandated required report since 1993 that asks, where do medical students go after they graduate? 5 to 10 years after they graduate. Are they practicing in primary care? Did they do their residency in primary care? Are they practicing in a rural area? And it consistently ranges between less than 1% to 3%, really. But this is just a slice of the overall pie. This is just looking at in-state medical school graduates across 6 of our medical schools, 2 of which are publics, ECU and UNC. So why is this number so low? And learning more about, how we were to allocate and implement this fund, learning more about graduate medical education, which really is after you complete medical school, you're matched into a residency program, can take 3 to 5 years or more with the fellowship to become a physician of what you decide to specialize in. So when we look at the primary care physician population that's actually practicing in rural area, it's very low, and that's largely because residency training is largely financed by Medicare, by the federal government. And the way that funding flows to states doesn't necessarily go directly to rural hospitals that could be in a position to train those residents. So there's many federal barriers. There's also been a cap on residency slots that have been funded historically by Congress, by CMS. There's other nuances to get around the cap, but ultimately, you know, the allowance for getting funding from the federal government to create more rural training slots for residents, especially in a rural area, there's difficulties with even making that sustainable or even getting it off the ground. So it really comes down to healthcare setting these federal barriers and the geographic and rural training time requirements. For example, if you're a critical access hospital, small hospital, 25 beds, you have to rely on an urban partner as part of your hospital system to receive full graduate medical education reimbursement from the federal government. If you're a sole community hospital, UNC Health Southeastern is actually an excellent example. In the last budget, it received one-time funding to sustain its residency training programs because by its hospital type does not receive full GME funding. Looking at the geographic and rural definitions, if a hospital wants to establish a rural training program, that training program needs to be in a county where the entire county is defined as rural. That is the federal definition of rural. As you're all aware, there are probably over 10 different definitions of rural. So, and not only that, but 50% of that resident's training time has to be in the rural area. So that makes it very difficult logistically to make this happen and sustainable. There are some areas of our state where this can work, but in many areas of our state, there are, you know, counties where there's metropolitan areas, but rural census tracts, you know, very rural areas. So we have designed a fund, I'll just get to it, but we have designed a fund from the 2023 state budget, $23.5 million, where we are making it easier for residency programs to be developed, to expand, and to sustain themselves, because we are lowering the threshold of required training time from 50% to 30%, and we are making the definition of rural training more flexible. So it doesn't have to be in a county where the entire county is considered rural in accordance with the federal definition. We're so excited about this fund working in tandem with the technical assistants, GME people at the SHEP Center, because there's so much untapped capacity in our state. Our state is the second most rural state, second to Texas in the nation. And so we feel that this fund will help ECU and UNC Health and their schools of medicine that have already done a good job by starting their own rural training programs on their own, taking it upon themselves. We're excited to build upon their foundation and to make it easier for them to develop and sustain these programs at a faster pace. So when we're talking about which physician specialties we're focusing on, some people call this the big six. That's family medicine, pediatrics, psychiatry, internal medicine, general surgery, and OBGYN. And before I showed you just a piece of the pie as far as where do in-state medical students go, but this is actually from a 2025 SHEPS data report, just updating on, you know, looking at the total landscape of where physicians are practicing. And 82% of physicians practicing in North Carolina actually completed medical school outside of North Carolina. So this fund is truly targeting training on the back end of a physician's education. And as you know, and as I mentioned, it takes a long time to become a licensed physician. And so we feel that this is the most efficient use of taxpayer dollars when it comes to creating more rural training opportunities and actual placements for strengthening the rural physician workforce. This is just a brief overview of how the allocations have been awarded since the UNC System Office received this appropriation. It has been divided between the UNC School of Medicine, ECU Brody School of Medicine, and the people behind me sitting here are all members of the SHEP Center who are part of the technical assistance team and also part of the nursing evaluation as well. So I just want to acknowledge that. And they're tremendous to work and partner with. So we have provided them some funding to provide technical assistance, looking at hospital cost reports, seeing if there's funds been left on the table when it comes to claiming residents, losing out on potential Medicare dollars. So it's been really helpful to learn from them with their expertise. But I will say that, you know, again, going back to the budget snappy, you know, it says we decided to expand the pool of eligible applicants beginning this fiscal year. So this is this is $23.5 million total award across the 23-25 biennium, but moving forward, it's an $8 million annual recurring appropriation. So beginning April, actually this month, we're going to be announcing awardees for this grant program that we have since created. So beginning in October of last year, we transitioned this fund to a grant program, expanded eligibility for who could apply, because yes, while strengthening the rural physician workforce is so key, you know, there are so many other health professions that are so critical to working with physicians in rural areas. And so we wanted to just expand the disciplines that all of our public university systems offer as well, because in the SNAPY, it does say that universities offering health affairs degree programs could also be a part of this fund. So back in October of 2025, we launched the grant program. January 20th of this year, grant applications were due. There are 4 different types of grants. I'll get into that in a second. This month, we'll be announcing the grantees. And again, the goal is to strengthen the overall rural healthcare workforce with this $8 million recurring. These are the 4 different types of grants. 3 of them are primarily GME focused. So you have development grants, expansion, and sustainability. Development grant, the max grant period for this is up to 3 years, going through the accreditation process, hiring faculty to oversee the program coordinators, program directors. It can really take up to 3 years to launch a completely new residency program. So the maximum award amount for that is $750,000. Once a grantee receives a development grant, it can no longer apply for that development grant in the future for that same program, but it could come back and apply for an expansion grant if they want to expand what they have created. ECU Health is doing a great job by using their allocation to expand existing accredited programs and just building out more rural track programs for the big 6, essentially. And then we have sustainability. The great example that I like to point out to is UNC Health Southeastern. They do not receive full GME. This is a great way for those that have a great partnership with Rural Training and our sponsoring institution for residents to sustain themselves if they don't get full GME by leveraging this fund, these flexible state dollars. And then innovation grants. I'm pleased to say that we've received over 30 applications for this $8 million recurring for this coming year, and 20 of them have come from innovation grant applicants across our public universities. Some of them are incorporating training with graduate medical education learners with residency trainees. Others are nurse-led clinics going out into new frontiers in Western North Carolina, working with nonprofit partners to serve as a clinical site. There's pharmacy, there's so many disciplines, social work, there's so many disciplines that are covered with these innovation grants that focus on rural training capacity expansion. And this, the max award amount for this is $200,000 as well, and it's for up to 2 years to use. So that is the end of my presentation. I'd be happy to take any questions.
Well, thank you. A couple of things. You're aware that we set up a scholarship loan repayment for physicians for rural North Carolina. Yes. And in talking and traveling around and meeting with everybody, the thing that I kept hearing is that the secret to keeping them is training them in recruiting from rural area, training in rural area, and then getting them married to somebody in a rural area. Yes. So I want you to add matchmaking to the list of things on there.
To the eligible uses.
But unless we get OBGYNs out in the rural area and pediatricians in the rural area, they won't have children and stay in the rural area again. So work on that for me also. Questions? Dr. Campbell, I'm going to call on you first because I know you've got a question.
No, and I appreciate this presentation, and I'll just kind of add to this a little bit. I know we've talked about this a little bit before, is it's probably close to 80% of residency graduates will take a job practicing within 50 miles of where their residency program is. It's not just a familiarity with the area, it's they've made contacts with existing physicians in that area. That's where they get a lot of their job offers. And quite frankly, speaking as someone who was finishing residency with medical school debt and making less than minimum wage as a resident, my travel budget wasn't that big to interview for jobs. But I applaud this, and I tell people getting training within those locales. Now, I understand that Cabarrus and Rowan are evidently urban focuses of North Carolina according to Rural Health Transformation Program. So I don't have a question per se, just to say thank you. I think that this is a fantastic idea.
Thank you. Representative Reeder.
Thank you very much for the presentation, both this one and the nursing. I think this is a good example of the state actually identifying a need, investing money into it, studying the outcome. And so we spend a lot of money up here. And so the fact that we've done this in a systematic way with outcomes is really important. And I'm hopeful with the money for the Shep Center, we will continue to study this. And I can't pass by without the call out to ECU. I was really proud when we had the first 6 graduates of the rural residency in family medicine. 5 of them were going to practice where they trained. And the one who wasn't was going to do a fellowship in sports medicine and plan to come back. And so I think that is a testament, as Dr. Campbell said, when you select and train people, they put roots down. And so my real question is, what more can we or should we be doing and thinking about as we go forward? Not just for medicine and nursing, but for all the health professions that we desperately need in rural areas.
Vice President Martin.
Thank you for the question, Representative Reeder. I think that's a great question, and just, learning more from the deans of health sciences at our schools, comparing that with looking at Shep's workforce, licensure workforce data, that's a big part of my role, and I'm learning more about other health disciplines, really, that are so key to training and practicing in rural areas that are so needed. And I'd just like to thank the fact that both of these funding pots are incredibly flexible, because it sort of gives us the freedom to decide what is needed at certain points in time or what to prioritize. I'd also like to follow up and say that I'm happy to say that ECU Health has been able, or Schools of Medicine and ECU Health has been able to use a portion of this fund to expand their rural family medicine program to get a complement increase from training 9 residents up to 27 residents at 3 of your ECU Health rural hospital locations. So thank you.
Senator Adcock.
Thank you so much. Well, those 2 back-to-back, that was definitely the 1-2 punch, right? How to get more nurses out there and more physicians and other providers in rural areas is just wonderful. So one of the things, remind me if I missed this, but in your first presentation, we talked about there was a benchmark set, produce 50% more nurses. Was there a similar, any kind of benchmark set for these funds? And if not, how do you, if you can, project what the increase will be in the big 6?
Yes. Thank you for the question, Senator Adcock. I would say we don't necessarily have a defined benchmark goal, but I think, just referring back to this annual report, referring back to, every 3 years, a periodic evaluation update on the whole entire physician landscape in North Carolina that's provided by the Shep Center. We are contracting with the Shep Center on this initiative, so this is something that we could certainly look at, and we plan to do by collecting existing baseline data from everyone enrolled these residency programs that receives a development expansion grant, and then just looking at that over time.
Follow up.
So thank you so much for that. My follow-up would be, so the intent anyway is to continue to look at this for as many years as you possibly can, because it takes a while to produce, for instance, a general surgeon, which we know we desperately need in these rural areas. It takes some time to do that. So I'm really glad to hear that.
Thank you.
Just one suggestion, we've talked about too, about bridging that second opportunity of loss, is, when we get them into underserved areas with that loan repayment, your worry becomes when that loan is repaid, have they sprouted roots to where they'll stay? And one suggestion I'll make to not only to ourselves with funding, but with getting flexible with these, one of the best ways to grow roots is ownership. Matchmaking may be better, but we'll see. But
Works.
But I would suggest that we look at some pilot programs that when we recruit them to these areas, that we offer them low interest or interest-free mortgage, not mortgages, but loans to build their own practice sites that they have ownership in. Looking at ways that once that loan is repaid, because right now the numbers are awful with loan repayment. I love loan repayment, please. I benefited from it. But the number of students, graduates that go to underserved areas with a loan repayment program, this is really high percentage that as soon as their loan is paid off, they leave. So looking at areas to hold them longer than that 4-year period is going to be essential.
Thank you. I hope you will stay around because I know some people want to ask you some other things and talk to you. So if you can, stay through the next presentation because I'm real excited about this next presentation. The CEO of First Health, I actually met him the first day that he came to work at First Health. So I've known Mickey a good while, but we were talking a number of weeks ago about independent hospitals in North Carolina. If I'm not mistaken, there are 10. You all are the largest. And so excited to have you all here today to talk about rural and independent hospitals. And Ms. Graham, are you going to go first? Go right ahead. You'll turn on your microphone. It's just a delight to have you all here today.
Good morning, and we appreciate the opportunity to be able to speak with the committee today. And Mickey sends his apologies for not being here. He did want to be here, but had another obligation. But again, we appreciate the opportunity to be here and talk a little bit about First Health and a little bit about rural access and independent hospitals. So I'll quickly go through the health system and a little bit about First Health. We are a 4-hospital health system located in the Sandhills, so we're an independent, locally governed, not-for-profit rural health system. Our hub hospital is located in Pinehurst. We've grown a little bit over the past 10 to 15 years. When I started, I've been there 33 years. And when we started, we had 1 hospital in Pinehurst. We were a regional referral center. And since then, we have 4 hospital locations. We have the rural, we have a critical access hospital in Montgomery County. We have a community hospital in Richmond County. We have the tertiary referral center in Pinehurst. And I like to say we had the first micro hospital in North Carolina in Rayford in Hope County. And then we have a large ambulatory footprint in Lee County. And I appreciated Ms. Martin's presentation because there's a lot of needs when it comes to physicians and in nursing, especially in the healthcare provider world. If you look at what types of services that we do provide, we provide acute care services. We have rehab services. We actually have almost 30 primary care clinics and a total of about 100 clinics over a 13-county service area. Health and fitness, we do have a behavioral unit. We have outpatient behavioral services. We have virtual care. We do provide EMS services in many of our counties. We actually have a dental program, home health and hospice, and many other types of services that you would expect a health system to provide. And we do a lot of that with a payer mix that's 75% of government payers. So Medicare, Medicaid, and TRICARE. And we fund a lot of our programs strictly with that type of payer mix. And if you look at our counties that we serve and the communities we serve, you see that payer mix throughout all of our communities. I mentioned a little bit about the service area. We actually serve about 1.3 million in our total service area. That's 13 counties in North Carolina and 2 counties in South Carolina. Our primary service area has about 300,000. That's where our hospitals sit. And I mentioned we have almost 100 clinics spread out throughout our service area. I can say, because I've been here for 33 years, how proud I am to work for First Health and how blessed I am to be part of this health system and to work with Mickey Foster. We are a top 100 8-time winner. We're the only hospital in North Carolina that's won that award 8 times. And what that award means, that's kind of the gold standard of awards in when you think about health systems and hospitals, because it covers everything: patient sat, quality, and financial performance. And we're also super proud of the Patient Experience Award. We've been a recipient of that for 18 years in a row, again, more than any other hospital in North Carolina. Again, we appreciate the opportunity to be here today and talk a little bit about First Health.
Tell us about the finances of running a rural hospital.
Yes, a little more challenging. So as Amy mentioned, we are very proud of those awards that she talked about, but we're even more proud to be able to deliver high quality, financially strong healthcare to our communities. But even strong systems like us are feeling increasing pressures. Rural healthcare is not just a provider issue, it's really an economic, public health, and community sustainability issue. Hospitals are often the largest employers in rural counties, and when rural healthcare weakens, communities experience a loss of access, longer travel times to receive care, economic declines because of loss of jobs, and worse health outcomes. So unfortunately, over 700 hospitals, this is a nationwide statistic, are at risk of closing because of financial problems. North Carolina hospitals are not excluded from this impending risk. Roughly half of rural hospitals across the country are operating in red, which is not sustainable. Access to inpatient care continues to decline in rural counties, and nearly 60% of rural hospitals across the country no longer are providing OB care, which means that expectant mothers have to travel oftentimes long distances just to be able to deliver their babies. So when we layer in the impacts of H.R. 1, it's going to be even more challenging for rural healthcare. H.R. 1 doesn't just affect our finances, but it affects what services that are going to remain locally. It may unintentionally accelerate rural service line closures, like OB services, oncology services, which are extremely important, behavioral health, and possibly even emergency services. So I'd like to provide a little more color around some of the challenges that we face at First Health and in rural healthcare in general. First being the workforce challenges, and Ms. Martin did a great job covering that as she talked about nursing, which at First Health for us also is the most challenging and largest issue we have. We also have other areas that we struggle with, imaging technicians, CRNAs, and other professionals. So what happens is we rely on contract labor, which increases our cost structure. And so these workforce challenges may become even more difficult as reduced margins from H.R. 1 is really going to limit our ability to offer competitive compensation. Another challenge we face, as Ms. Martin also talked about, is physician recruitment and just the national shortages. This is even more challenging, though, in rural markets where we have a higher cost to recruit and to retain those physicians. And then rural populations experience, as you all are probably well aware, higher chronic disease rates, greater transportation barriers, food insecurities, and other health inequities that make it difficult and more costly for us to provide those healthcare services. Then to touch on Medicaid. So Medicaid is a primary payer in the pie chart you saw that Amy presented. It is a primary payer in our rural market, and the current reimbursement that we receive does not reflect the actual cost to provide that care. So the rebase needs fully funded to reflect the current economic reality with inflation and just the cost structures that we have in place today. And then lastly, there are various proposed state and federal policies that increase our financial risk to First Health and to the rural hospitals across the state. So next I want to show you this graph, and as Amy mentioned earlier, First Health is one of the strongest independent health systems in the state financially. We are very fortunate with that. But we've been operating historically with about a 3% operating margin. And that's actually a relatively thin margin, but it has allowed us and does allow us to reinvest those funds back into our workforce, in our infrastructure and facilities, and also keep up with the latest technologies. What you can see here, though, is that our operating margin forecast from 2026, which is on the far left-hand side, through 2032, which is on the right-hand side, we start to see a decline. And you can see that starting in fiscal year 28, and then it continues to trend downward from there. And by 2032, we will actually be at an operating loss, so we'll be in the red at that point. And I should also mention, this forecast is solely based on the impacts of H.R. 1. So it does not factor in any other reimbursement loss or policy changes that may occur in that time frame. So we can't let that happen. We're not going to let that happen, but we would respectfully like to ask for your help. So in healthcare, we are guided by a foundational principle in everything we do for our patients. And that principle is first, do no harm. So we are asking you to apply that same principle to the healthcare policy decisions that you make. So at a time when hospitals in North Carolina, especially rural hospitals like us, are under these significant pressures, the policy choices you make can either stabilize care or it could unintentionally accelerate its decline. So our ask is that you would avoid any policies that would exacerbate our financial risk, such as Medicaid rate cuts. And I mentioned earlier, Medicaid funding is not just coverage for the vulnerable patients that we have in our state, but it's really the financial backbone of rural health care. Rural hospitals also cannot afford a loss of property tax exemptions. This would be a direct hit to a bottom line that, as I've shown you, is already declining. We also can't afford a loss of CON protections, and we would like to thank the General Assembly for what you've done with the CON protections that you've already put in place a couple years ago. Really thank you for supporting that. That's been helpful. And then also rural hospitals lack the infrastructure and the capital to absorb costs that are associated with unfunded mandates. So in closing, policy decisions that you make today will determine, number one, whether rural hospitals like First Health remain independent, or in the case of more vulnerable hospitals, whether they survive. And number two, whether our rural communities in North Carolina thrive or whether they decline. Because frankly, when a hospital is harmed, a community is harmed. So that's all the slides we have today, but we are happy to take any questions. Thank you for having us.
Thank you. First of all, Ms. Graham, the word retire is not in the Bible, so you cannot leave, so you stay there. I'm sure Mickey would support that. Ms. McFain, would you tell me two things? What percentage of your workforce budget, your nursing workforce budget, goes to contract nurses, if you have that roughly? And how much money did you all receive from 340B last year?
So your second question I can answer right off the top of my head. So 340B savings is about $40 million for us.
So I'll follow up with that. So if that was changed, that's bottom line money for you, right?
Exactly. It's direct to the bottom line.
And then do you have any idea?
The
about
first
the contract?
question, so roughly, do you know how many FTEs we have in agency? I want to say it's around 80 nursing FTEs. So probably about 10% of our nursing workforce is currently agency.
And how many are foreign nurses?
That I do not know. I apologize. Very small number.
Fair. Questions? Senator Adcock.
Thank you, Mr. Chair. Great presentations, especially the end. That call to action is very clear. So one of my takeaways from everything that you've said is, with these very thin operating margins and the risk of our hospitals closing, there's additional risk. And that is, even if they're not, when you're at that 11th hour and you look like you could close, other options that you would never consider begin to look attractive, like private equity purchase and selling to a larger system and becoming consolidated, so you've got the protection of the mothership. And we know that there are problems often with both of those. And so all the decisions, policy decisions, as well as money decisions that we make, can put these rural independent hospitals in untenable situations, right? Of having to make some choices you would like to not make. It's close or sell out to private equity and get the cash that you need. It's close or stop delivering babies or stop providing other services that really are essential if you're going to have a community that's going to grow, or close and become part of a bigger system that there's many arguments out there that say doesn't really save money, right? And doesn't extend access. So I hope we all have really heard your message today and take it to heart, that closure is one bad option, but there are other bad options out there for you. So thank you so much for your presentation.
President Blackwell.
Thank you, Mr. Chairman. I wanted to ask you about your chart that shows your operating income and margins. The way you have presented this information suggests to me that you are totally victims of whatever the state and federal government does, and there's nothing that you all can do independently of us or the feds to improve your margins. Is that basically what you're telling us?
Okay.
Yeah, thank you for the question. Not completely. I mean, we definitely can intervene with certain things, but they would not be popular. Closing service lines that aren't profitable, for example, which isn't something that you want to do in a rural county, as we discussed. We can do things, and we are, like working with our GPO, for example, to save pricing on our supplies. Getting better pricing deals, looking at our staffing models to improve productivity and be more efficient in what we do, looking at our revenue cycle. So how can we improve our reimbursement overall, not just from Medicare and Medicaid, but from the commercial payers that we do business with? How can we improve what we collect, reduce denials that come in, those types of things for revenue cycle operations. So we are looking at doing all of those things to help improve our bottom line. But to make up for that kind of a gap with just what HR 1 does, it's going to be very, very difficult to do that.
Follow up?
Yes, sir. Follow up.
On the following page, about avoiding state policies that exacerbate financial risk to rural hospitals, are there specific unfunded regulatory mandates that you have in mind that are proposed or that are already in existence that references?
One that comes to mind would be just reporting requirements. We have hospitals have so many regulatory reporting requirements that have to be met, not just at the state level, also federal level, that are costly and sometimes an administrative burden to handle. None comes to mind that have been proposed currently. And I don't know if you can think of anything, but.
Representative Campbell.
Thank you, Mr. Chair. I do, before my question, I want to give First Health a compliment that you evidently in Lee County have a very effective program specializing in patients that are very stubborn and don't listen to their family members. And I want to let you know my dad is doing quite well. Thank you. And I know you don't have a specific number for this, but you know, I often lament the exponential growth of administrative employees in healthcare versus providers, but also have to recognize our guilt in that in terms of regulatory burden. Do you have an idea of the percentage of administrative costs to your hospital that are related to regulatory issues?
I would say of our total expense, and this is something I think we report on our 990 that we file, it's probably between 10 and 20% overall.
Okay, Co-Chair Potts.
Thank you for your presentation. As we know, when the federal government looks to balance their checkbooks, they usually look downstream to the states and the counties. And of course, you're aware HASP is being renegotiated as a part of HR 1. If your hospitals are your hospitals licensed separately? Do they fall under one governing organization, one body? And do you know how much that your 6 hospitals received in HASP dollars last year? Thank you.
Ms. McFain.
Yeah, I believe the net, and this is for all of our locations, after provider tax, the net benefit, I believe, was around $70 million.
Representative Cunningham.
Thank you, Mr. Chair. Thank you for the presentation. As an independent, as your functioning is minimal now, you say it's only 10 across the whole state, that's minimal, because most of the smaller hospitals in the smaller counties went ahead and went up under a larger entity, and you're saying that now you're looking at the survival of you all as an independent in North Carolina, and it seems to be a hard place to be. The trauma center connected to you all, is that still the biggest hospital that's in Pinehurst?
Ms. Graham.
It's not a trauma center necessarily from a designation, but yes, the hospital in Pinehurst, Moore Regional Hospital, is a rural referral center, and we provide all services except trauma, burns, and pediatrics, so specialties.
Okay, thank you. So I heard what you said about the detriment of the hospital closing. We've seen a lot of them close in other rural areas, Anson County being one that had to do an independent primary on one side, and then an emergency on the other side, and then a helicopter in the back to fly them up to wherever. If they have a heart attack, they got to move much faster. And so that's been going on quite a while. My question is associated with Critical Access Hospital. You all are independent. What would push you into being a critical access hospital?
We actually have a critical access hospital in Montgomery County. And, you know, critical access hospitals aren't extremely profitable, but they are so needed in those rural communities. And we are actually expanding, building a new, we're investing about $50 million, close to $50 million in Montgomery County to build a new critical access hospital. So we are making that investment, even though, you know, the return on it is not great.
Thank you.
Vice Chair Galey.
Thank you, Mr. Chairman. I wanted to go back to where you talked about the loss of certificate of need protections for rural care. I'd like to hear something about, or more about, your basis for saying that. I understand that Texas repealed certificate of need laws in 1985, but it's not expanded Medicaid. So while Texas may have had some rural hospital closures in the wake of repealing certificate of need, I'm not sure that we can compare North Carolina to Texas. Also, it has really large rural distances. Florida repealed certificate of need laws between 2019 and 2021. I understand that Florida now has more total facilities in smaller and more distributed sites. While they did have 3 rural hospitals that closed, 2 of those didn't close completely. They converted to freestanding ER facilities. So many people say that there's no demonstrated link between CON repeal and closure of rural hospitals, that you end up with more providers overall, especially in urban and suburban areas. So what would you cite as being, having other states as the example now for quite a number of years? South Carolina, they say, is too new to compare or to really foreshadow what the repeal of certificate of need is going to have in South Carolina. What's sort of your basis for saying that if we change our certificate of need laws, that could have an impact, a negative impact on rural care?
Ms. Graham?
From the rural perspective, and it goes back a little bit to the workforce component of that, I don't think we know yet enough about what the impact of the CON changes from a couple of years ago since they went into place just in this past November. But just thinking about workforce and physician needs and the duplicate services, often when you've got competing services in and coming into different markets, we're all going to be competing for the same workforce and the same physician manpower. And I think that becomes difficult, but more to come when it comes to the changes that were made a couple of years ago with the CON changes.
Follow-up?
Follow-up.
Are those challenges unique to North Carolina, or are they also more than likely present in Texas and Florida?
Ms. Graham?
I don't know enough about the Texas CON pieces and how that has worked there, but there are challenges across the nation, of course, when it comes to workforce.
One final question. What are the least profitable service lines in your hospital?
Probably behavioral health services would be one of the top. Emergency, OB, those much needed services that are needed in rural counties are the ones that are also the least profitable.
And cost the most.
And cost the most, correct.
One more question, because I had this conversation. Do you know what it costs to keep an involuntary committed person in your ER for 24 hours?
Not off the top of my head, I do not.
Would you get that?
We can get that for you, definitely, yes.
Thank you. That concludes the meeting. Thank all of you for being here. If you have any follow-up questions, if you will submit us to us, we will get them to our presenters and get you answers back. We are adjourned.